The next session is by Dr. Petros, who is a consultant endocrinologist and visiting senior lecturer in the Newcastle University, UK. His area of interest lies in endocrine diseases in the research, and we are glad for his online presence and talk regarding the interpretation of the abnormal thyroid function tests.
Ladies and gentlemen, thank you again for the invitation. It's a great pleasure.
And we are hoping that he'll be available later for panel discussions and answering any questions at the end of the session.
Ladies and gentlemen, thank you again for the invitation. It's a great pleasure to be with you for this meeting. I'm going to start by taking you back in time to 1912 and tell you about this gentleman, Frederick Gudenach. He was a scientist and in 1912 conducted an important experiment. So he took a tank full of tadpoles and made an extract of horse thyroid glands. And this extract, rich in thyroid hormones, he poured into the tank. And what he observed over the next couple of days was something really spectacular. The tadpoles turned into frogs at a much more accelerated rate than his control tank. And this was the first bioassay ever put together for thyroid hormones. And in fact, it is still around. It's known as the amphibian metamorphosis assay, and it is used extensively by environmental agencies to monitor the environment and water in particular for thyroid hormone disruptors, because disruptors really act very specifically on the T3 receptor and influence metamorphosis. So in the many decades between the first bioassay and what we have now, things have really taken off. And what we have now is a technology where we can assess thyroid function with assays that have high performance, automated, cheap, quick, and in a sense, the victims of their own success, because it is so easy just to tick the box for thyroid function tests and have a result, when there's not always a good reason for doing so. So what I'd like to talk about in the next 20 minutes or so is use and abuse of thyroid function tests, hone in on the concept of pre-test probability, say something about assay interference, finding blood tests because of what I call bad patient behavior, and a number of pathological states that give rise to intriguing biochemical profiles. And I'll finish off with my key messages. So if you invest in the stock market, you may be interested in this. This is a tip. If you have some spare cash, invest it in thyroid function test diagnostics. And the reason I'm saying that is that analysts give some interesting information about the size of the thyroid function test market. 1.4 billion in 2023 and expected to rise to 3.2 billion in 2031. That's a growth rate of about 11% that beats any bank. If you look at what has happened in the UK with thyroid function tests in the last 15 years, there's been a threefold increase in requests. And the main drivers for this seem to be telemedicine, remote testing, and direct-to-consumer testing. Now, this has really saturated more or less the market in the Western world, and the industry now is targeting other regions, especially the developing world. And direct-to-consumer testing, if you don't know what that is, well, it is the one that has really grown in the last 5 years. And this is about patients, the public, anybody, ordering a kit by post, which arrives, and then you do a finger prick, and you send the sample back, and you get the results. This particular one is actually promoted, I'm sorry to say, by the NHS itself. And I don't approve, by the way, and I'll show you why. So the diagnostic process is composed, in my view, of 3 important pillars. It's the history, the examination, and the additional tests. And that's how you arrive at the diagnosis. Now, if you skip the first 2 steps, then you're in the domain of screening. And screening is important, and it became really very studied in detail by these 2 physicians, Max Wilson and Gunnar Jungner, back in the 1960s, who really expanded our knowledge about screening. And indeed, the WHO adopted their kind of views and experiences. And for screening to work, you really have to tick all these boxes. And our thyroid function tests probably tick all of these boxes, with the exception of cost effectiveness. And the only evidence-based screening program in hypothyroidism is in congenital hypothyroidism, the heel prick test that babies get a week or so after birth. Now, we do screen for hypothyroidism in a variety of other situations, but the evidence that this is actually helpful is not that clear. And so if you skip the first 2 steps, then you're at risk of the 3 pillars of diagnosis crumbling and being misled. And it's a bit like shooting in the dark. And so the pretest probability concept is really important when we think about thyroid function tests. And just to give you an example, if you think of somebody who's complaining of tiredness, the likelihood ratio is this, and it turns out to be 1.4 for tiredness. And then if you ask this important question, then you can work it out by the pretest probability, which is the product between the prevalence of the disease and the likelihood ratio. And this is data that are available for most of the symptoms of hypothyroidism. Now, it turns out to be 0.8%, which means you have to test 125 patients presenting with tiredness before you actually diagnose one with overt hypothyroidism. And if you look at all the other symptoms of hypothyroidism, they're all associated with a low pretest probability. If you combine symptoms and signs, you get a slightly better result, but still not that good. So what's the most effective way of getting rid of strange, weird thyroid function tests? Well, the answer is don't do them in the first place if there is no good indication for doing so. So I think there is a need to educate colleagues in primary care who, certainly in my experience, are ordering thyroid function tests when there is no good indication, and this may account for why so many thyroid function tests are being done in the UK. So let's just focus a bit on weird thyroid function tests. And the first category is that this could be because of interference with the assay. And the question is, faced with weird thyroid function tests, what is the most important investigation? And I would argue that it is a localization test, and that's to localize your clinical biochemist. And I've been very fortunate over the years of having really valuable clinical biochemistry colleagues, the most recent one, Chris Boot. Whenever I came across such a situation, I would ring him and Chris would just get off and do all the necessary and usually come back within a day or so and give me the answer. So collaboration with the lab is really important. So heparin is one of the culprits. What it does, it activates endothelial lipoprotein lipase, and that releases large amounts of free fatty acids, and they can displace T3 and T4 from binding proteins in serum. So you get an unusual result with high free T4 and free T3 and a normal TSH. And the same also can happen with high dose frutamide, the kind of doses that cardiologists and nephrologists use. Another way that acid interference can occur is with biotin. So biotin, as you know, is a vitamin, and certainly in the UK, we've seen an explosion of people buying supplements and vitamins from pharmacies without prescriptions and taking them. So this is increasingly a common problem. Now, biotin binds very avidly to another chemical called streptavidine that is used in many of the assays, amino acids for thyroid function tests. And if there's a lot of biotin hanging around, then it gets it interferes. And funny enough, it can actually look like proper thyrotoxicosis because the effects of biotin on the free T4 and free T3 assay are the opposite to those on TSH. So you can have a high free T3 and free T4 and a suppressed TSH that really confuse you because usually the patient looks entirely euthyroid. And the answer to this is you get patients to stop taking biotin for 2 or 3 days and you repeat the blood test. Then there is macro TSH. So this is similar to macroprolactin that endocrinologists are more used to. So there are immunoglobulins that bind to TSH. They don't alter its biochemical activity, but they give a falsely elevated TSH. And some of us have heterophil antibodies to mouse or rabbit immunoglobulins that interfere with the assay. And that can give usually a high TSH, very occasionally a low TSH. And there are some really rare situations. There's, for example, a variant of the beta subunit of the TSH molecule, which happens to be the site that antibodies bind to for assays, and that can give a low TSH. And occasionally you get the situation with paraproteins. And again, very rarely, some of us can have antibodies to T3 and T4, or genetic variants of binding proteins that can give abnormalities in free T3 and free T4. So apart from true acid interference, there are funny things that people do that can give rise to weird thyroid function tests. And in that situation, you may need to wear your Sherlock Holmes hat to try and understand what is going on. So let me give you an example. This was a patient who had a psychiatric background, also had hypothyroidism, and came for routine assessment. The clinical examination showed that she was euthyroid, but this was the thyroid profile. So low T3, low T4, and low TSH, looking like central hypothyroidism, but she was euthyroid. Anyway, cut a long story short, the culprit was that this patient was actually taking Triac, which is a thyromimetic molecule, really hard to get a hold of, but it acts like thyroid hormones. So she was taking doses that were sufficient to suppress her own serum TSH because she was hypothyroid and she was not taking levothyroxine. Free T4 and free T3 were undetectable, but she was clinically euthyroid because Triac actually mimics the effects of thyroid hormones. And here's another example of an older woman who is taking a rather large dose of levothyroxine in addition to lots of other medications. And there is already a history of kind of erratic, unstable thyroid function tests in the past. So again, she comes for a routine clinic appointment. She's clinically euthyroid, but this is her thyroid profile. So she's got a high 3T4 and a high TSH. Now this is beginning to look a little bit like a TSH producing tumor or thyroid hormone resistance, except that previous thyroid function tests have been normal. So what happens here is this is the typical example of the chronically incompliant patient who doesn't take the levothyroxine, so they have raised TSH and a low 3T4. Then they realize there's an appointment coming up with the endocrinologist, and they start taking the medication, and because they've missed some of them in the past, they're taking more than they usually prescribed. And so what happens then is that the 3T4 levels in the bloodstream rise, and rise relatively quickly, but the pituitary and hypothalamus are a little sluggish, especially in older people. So they take longer to come down. And there is therefore a window of opportunity here where both 3T4 and TSH are elevated. And if that happens to be the date of the clinic appointment, you get these weird thyroid function tests. Now here's another example, a young man with congenital hypothyroidism and obesity who is supposed to be on levothyroxine at a reasonable dose, comes to the clinic and he is clinically thyrotoxic. And this is his profile. So again, this is weird. Undetectable 3T4, greatly raised 3T3, and a suppressed TSH. So after some questioning and prodding, it turns out this patient was buying T3 and taking it at very large doses. So the 3T3 would be elevated. He has no thyroid and cannot make T4. And of course, the TSH is suppressed because he's overdoing it. And then there are pathological states for having unusual or weird thyroid function tests. And I'll just take you through some of these. And this is another example of the endocrinologist on call receiving a message from the GP. And the problem here is that this is an elderly man who has complained of recent onset of fatigue. And what the GP has done is he's done a COVID test and in addition has done routine blood tests. And it turned out the COVID test was positive. So this is a decent explanation for the patient experiencing fatigue. And it's a shame that the GP has done routine blood tests because that would not have been necessary. But the blood tests come back and they cause a bit of a headache. So the 3T4 is normal, but this patient has a low T3 and a low but not suppressed TSH as shown here. So the endocrinologist gets a panicky call from the GP asking for help. Well, this is fairly typical of non-thyroidal illness. And the key message here is if your patient has an illness, then avoid testing thyroid function tests unless there's a very good reason for it. So what happens in non-thyroidal illness is that there is, in the early phases, inhibition of T4 to T3 conversion. And this is probably due to the cytokine release as a result of the illness. So if you inhibit T4 to T3 conversion, what happens is the T3 goes down, that's the red line, and the free T4, the white line, goes up. And the hypothalamus and pituitary are very sensitive to T4, so because the T4 goes up, the TSH, the yellow line, goes down. And if the illness progresses and the patient becomes critically ill, then the pituitary hypothalamus shut down, and you get a profile that looks like central hypothyroidism. If the patient recovers, then everything comes back to normal, but very often the TSH overshoots during the recovery period. And at that point, if you do thyroid function tests, you may get a profile that suggests subclinical hypothyroidism. And after a few weeks, everything settles down back to normal as long as the patient indeed recovers. And there are a number of other situations where T4 to T3 conversion can be inhibited, mainly drugs. Selenium deficiency is really, it has to be very severe selenium deficiency for it to happen. Now, there are a number of very rare conditions that can lead to abnormal thyroid function tests with raised 3T4 and 3T3 and normal TSH. Of these, over 40 years, I've only come across dyshomogenesis. The others are extremely rare. The usual scenario, though, that I think all endocrinologists will face or do face from time to time is this one: patients with raised free thyroid hormones and either raised or normal TSH. And the usual kind of question is whether the patient has thyroid hormone resistance or a TSH producing pituitary tumor. And give you another example. This is a 40-year-old guy from the forces that presented with atrial fibrillation. He was clinically possibly mildly thyrotoxic, and this was his thyroid profile. So raised 3T4 and 3T3 with a high normal TSH. So what test do you do in this situation? And I'd just like you to think about all these options. I've deliberately added an odd one there just to tease you a little bit. MRI scan, which is an imaging modality. And the reason I put it there is just to remind you that MRI pituitary is a localization test. It's not a diagnostic test. You only do localization tests when you've arrived at a biochemical diagnosis. And if you do it at the outset, it may well turn out to be misleading, because about 10% of normal people will have some minor abnormality on their MRI pituitary. So what tests can you do to distinguish between the TSH producing tumor and thyroid hormone resistance? We can look at sex hormone binding globulin, which is in some ways a biomarker of thyroid status. And you get this kind of result if you look at a large number of patients. So it may be helpful, but there is an overlap, and that is not terribly useful. And if you look at alpha subunit, which tends to be secreted in excess in TSH homers, or you do a T3 suppression test, the results are rather similar to the SHBG test that I show you here. In other words, there's considerable overlap, and it's not particularly useful. But the old-fashioned TRH test, which we used to do many years ago, and still do for this particular indication, can be helpful. And here you can see a much better separation between the two. So patients with thyroid hormone resistance tend to be much more responsive to TRH than the TSH homer, which is partly autonomous. And the other test of some use is a response to octreotide, because TSH homers are exquisitely sensitive to octreotide, and TSH will go down very rapidly. In fact, sometimes it will cause transient hypothyroidism, whereas you get very little response in thyroid hormone resistance. And so my conclusions and key messages, ladies and gentlemen, are to remember the three pillars of diagnosis: history taking, examination, and tests. And they all need to come together to try and make the diagnosis. Secondly, I think there is a need for us to use thyroid function tests sparingly and intelligently. And one key aspect of how one manages with thyroid function tests is our relationship and collaboration with clinical biochemists. Thank you very much for your attention.